Femoral head fractures. 1. Epidemiology. Femoral head fractures are rare and are usually associated with hip dislocation. 2. Classification. Pipkin subclassification, based on location and type of fracture. Type 1. Femoral head fracture inferior to the fovea centralis. Type 2. Femoral head fracture superior to the fovea centralis. Type 3. Femoral head fracture with femoral neck fracture. Type 4. Femoral head fracture with acetabular rim fracture. 3. Imaging. X-ray, AP and Judet views. CT, used for more detailed evaluation. 4. Treatment. Reduction of hip dislocation. Since femoral head fractures are often associated with hip dislocation, reduction of the dislocated hip should be performed first. Management based on Pipkin classification. Conservative. If a stable reduction is achieved, traction for 4 to 6 weeks may be used, particularly if there is less than a 1 step off. Open reduction and internal fixation, ORIF. If anatomical reduction is not achieved, ORIF is indicated, usually through an anterior approach with Herbert screws or countersunk lag screws. Excision. If the fracture involves a small fragment that does not compromise stability, excision may be considered. Young patients. ORIF of the femoral neck followed by ORIF of the femoral head through the anterolateral, Watson-Jones, approach. Elderly patients. Prosthetic replacement may be considered for those with significant fractures or osteoarthritis. 5. Complications. Avascular necrosis, AVN, due to disruption of the blood supply to the femoral head. Osteoarthritis, OA, long-term consequence of untreated or poorly managed fractures. And 6. Management based on associated acetabular fractures. The presence of an associated acetabular fracture will influence the treatment plan, determining whether conservative or operative management is needed. If surgical intervention is necessary, ORIF of the femoral head fracture may still be required, even if the fracture is non-displaced.